that they were pretty overwhelmed with the, when they had a big influx of patients, just like we had in the New York metropolitan area. And so what is that going to happen? What's going to happen going forward? I thought about it a little bit overnight, and I think the first thing is in most of the Western countries that we're certainly going to have manufacturing on site for critical PPE and things like that, respirators, because what happens is because there's global outsourcing now of almost all products, people go to the lowest bidder, and not every major country now has manufacturing to suit it for its own needs. So I think that's the first thing that we're going to see, that all the governments in Western Europe and the United States, et cetera, are going to say what products are really essential, what do we really need to manufacture in our own country. The other thing is, I think that there really has to be more cooperation in the public health sector between countries. Certainly we do have WHO, but we do have to enhance the surveillance systems around the world. I think we've noticed in the last 20 years, we've had SARS and MERS and H1N1 and Zika and Ebola and so on. That anything that happens anywhere in the world is within 24 hours flight from anywhere else. So it's going to affect anybody else anywhere in the world. So I think that we're just going to have to cooperate more between countries to collaborate on fighting out these outbreaks. Of course, this was the biggest thing, this pandemic, but even small things that occur all the time do need coordination. I think in terms of if we do see a second wave of cases, I don't think the crunch on the ICU will be quite as great, because now everybody is realizing that we don't have to intubate all of these patients very quickly like we were initially, and then we ran out of ICU space and we ran out of ventilators. They're using high flow oxygen and CPAP and things like that to prevent intubation is a viable alternative for a lot of these patients. So I'm hopeful as we go forward, if we do have a second wave, that the gigantic crunch on the ICU beds will be alleviated a little bit. So that was sort of my just a couple things that I thought about overnight related to that question about how it's going to affect the future of medicine. And I think, of course, in the United States, we're really going more towards, telemedicine for chronic diseases. And I think that trend will continue. That's outside of, that was a trend that was already happening before COVID. But I think the trend to manage people from home will probably continue even after COVID is over.
Thank you. Yeah, definitely a new world with that. So we're getting a few questions in our chat box. The first one is it possible to get clinical work experience in the US? Actually, there's another one related to that. As a Pakistani passport holder, do I have any chance to apply for work in the US after graduation? No, I want to take a stab at that.
Does anybody know? I'm not
as
sure.
Far as,
it depends upon who wins the election, I guess.
True statement on that. But at least what I have known, because I do know a couple international medical graduates. So you do have to complete your USMLE. So step 1, step 2, step 2 CK versus CS, it's both, as well as step 3. Once you have all 3 tests done, then you may apply for residency here in the United States after you graduate medical school. Again, the medical degree has to be sent over, and you have to look into each individual country, what are the visa requirements. But it is possible to come over here for clinical work as well. And I think Barney was talking about this the other day. He did have a student do research with him who was from the UK that is now back in the US. Is that correct, Barney?
Yeah, we had but it was a student from Great Britain, so I'm not sure. I think that with regard to Pakistan, I think it may be on the list of, at least with this current administration, on the list of folks that can't come to the United States, but I don't know that for sure.
Yeah.
and this was probably 20 or 25 years ago, so things may have changed. I don't know. I think that I don't does anybody on the call remember? John, do you remember any foreign medical graduates rotating through the emergency department? I don't think so, but I'm not sure.
I'm not sure, although there are many internal medicine residents who are from overseas.
Yeah.
Particularly, it seems like the Middle East. We have a lot of residents in internal medicine from the Middle East. We have some who were residents and are now attendings from Palestine, from the West Bank of the Jordan. And we've had some Lebanese.
Yeah, I would suspect that Bulgaria is not on the list of countries that can't come to the States. So I think there's a possibility. And and as Dr. Allegra pointed out, there are a very large number of foreign medical graduates that are internal medicine residents. And we do have some, even in our residency, we have some, I guess, minority folks in the residence, a number of minority folks in the residency. One of our graduating residents was originally from Albania. And of course, Shelley, were you born in the States or were you born in?
I was born in the States, yeah.
So, and we have we have a Sikh in our residency. We have a few folks who are Muslim in the residency. So we try to be fairly open, but I think that, and I would guess that would be the case for the internal medicine residency. So if you were thinking of doing a residency in the United States, I think it's certainly possible. As for medical students, I don't know whether those folks apply, the foreign medical graduates that are in the internal medicine residency, whether they rotated through internal medicine at Morristown, or whether they, I don't know how that happened, but I think there's a possibility, at least, of doing a residency in the United States. I don't know about foreign medical students in the emergency department.
Got it. Yeah. So best thing that we could tell you is do a little bit of research. And also there's no harm in emailing people. You can always email either the head of your medical school or a hospital. The worst that they could say is no. Okay. So then on to our next question. Do you know if you can use coagulants to reverse the effects of anticoagulants on a stroke patient that was already on anticoagulants?
The only coagulant that you might consider in somebody with intracranial bleed would be a tranexamic acid, but I don't know that. I don't know. I know that for traumatic intracranial bleeds, I think that there may be studies that show that tranexamic acid works, but in terms of the other, I don't know.
Yeah, and it also depends on what kind of stroke it is. Is it hemorrhagic? It is ischemic. Because if it's ischemic and you're on a blood thinner, they're not going to do TPA. But if they are on, if it's a hemorrhagic stroke, then as Dr. Fiesler said when he gave that lecture, you want to reverse if you can, because they're actively bleeding in their brain and you need to stop that. So yeah, with warfarin, as Dr. Anton had wrote in the chat, you can use like vitamin K, also FFP for fresh frozen plasma is a great reversal agent as well. So these are all important things that you should consider when someone has a stroke. It just depends on what type of stroke. So you always want to make sure you get that CAT scan to confirm. All right. Okay. Oh, I got one. How to become one of the team members of MEDIPATH. We did create our first large team this year. Last year we only had some volunteers, so we had applications before the school year. So we will have that on a yearly basis. So most likely it'll be in the summer, but we're happy to take on volunteers for future events. So if you want to be added to our volunteer list, we could always use the extra set of hands for future events. So you could just email MEDIPATH and give us your full name and phone number as well. We have a WhatsApp group for that. Okay, and do you offer electives to international medical graduates in your hospital in Morristown? I think we offer residency. I'm not sure about electives. I believe in internal medicine, they have a couple med students from overseas, like from the Caribbean at least.
I think that's true. I think the majority of students in internal medicine at Morristown are from overseas.
Yeah, 100%.
Is that right?
Yeah, most of them are actually, I would say like at least, I want to say like 40% of them. So yeah, I would definitely do that. All right. I did get a question the other day. I didn't actually answer. It was just a personal text to me. But I'm going to ask all you guys, what is your most memorable case you had to treat?
Shall I go first?
Sure.
A case that was most satisfying to me was a case that I was on a medical mission to a place called St. Lucia in the Caribbean. And someone came in with a dense stroke. They were about 60 years of age, a heavy smoker. In fact, the guy was smoking when he showed up with the stroke. He had signs of severe pulmonary disease with clubbing in his fingers. And I said, the only thing I can do in this setting, I didn't have any thrombolytics or anything available to me, was to check a hemoglobin and take some blood off if the hemoglobin was high. And sure enough, the hemoglobin was 20. And the upper limits of normal, 15, 16. So I called the person who deals with this, taking off blood at the hospital. It was a Saturday night. I was on call. And he says, I'm at a party. I'm not going to come in. I said, you better come in. So anyway, he comes in, takes 2 liters of blood off, and the stroke completely disappeared. As he became completely functional. So that was one of the more satisfying cases for me in my career.
That's remarkable. That's totally remarkable. It just shows you that if you use your imagination, sometimes you can get things done that you wouldn't normally expect to be able to do. Wow, that's terrific, John.
Yeah.
I had a case of about a 75-year-old man who came in cardiac arrest, previously full functional, and had recent surgery for an appendectomy. And at first I thought that the reason he was in cardiac arrest was that he was losing blood, but his hemoglobin was normal. And we were fortunate to have a ultrasonographer one of our attendings was good at ultrasonography. I'm not very good at it. And he, first of all, found that he put the probe on the patient's heart, and the right ventricle was huge. And then we he also found a DVT in the leg. So we pushed thrombolytics. We pushed TPA 50 milligrams, and the patient his heart started beating again, and he ended up walking out of the hospital. So it was I think a remarkable save, and a result of a collaboration between myself and another physician in the emergency department. So just as Dr. Allegra had really saved this guy's life by something simple, at first when I saw the patient, I thought maybe he was bleeding out from the surgery. It was also interesting because he had a CAT scan that was done. I don't remember why it was done, but it showed that he had some kind of mucus abnormality of his appendix. And they said, "What should we do?" And he said, "Well, don't do anything." And then he said, "No, I want to take it out." So he had a sort of I'm sorry, it wasn't that. He had a colonoscopy. My mistake. And the reason he had a colonoscopy was because he was of such an age that his wife kept on badgering him to have a colonoscopy. He said, "You better have a colonoscopy because of your age, and you want to make sure you don't have cancer." So they found this abnormality of the appendix. It wasn't appendicitis, it was some kind of mucoid problem with the appendix. And as a result, they took out his appendix. So the guy was almost killed by a colonoscopy.
Wow.
Okay, I've had several cases over the years. I'm an infectious disease doctor, and some infections that are more of the tropical nature we don't see very much in the United States. But I remember one night, it was a Friday night, that a 35-year-old guy came in with an encephalitis. And he had this strange look on his face. They call it the sardonic look on his face, like of almost abject terror on his face. And, I'm sort of thinking, why would this guy have encephalitis? So, I was asking him typically, I was thinking, well, maybe that's a typical thing that you see with rabies. We hadn't seen a case in rabies in 25 years in my state of New Jersey, but I just had a hunch. So I called the dermatologist, and as you know, dermatologists don't come to the hospital very often for consults, particularly Friday night at about 10 o'clock. And I asked one of my friends, I said, "Would you come and do something for me? I want you to do a posterior neck biopsy right at the hairline in the back, because I'm worried about rabies." And he says, "What? Are you kidding?" And so he says, "Okay, I'll come in." So he did the biopsy, and 3 days later, we got a confirmatory back from CDC in Atlanta that it truly was rabies, and it was a bat-related rabies. That's most of the rabies we have in the United States. We have about 2 cases a year, so we don't see very much. We don't see the dog rabies so much as seen in other countries. And it's sometimes very hard. In retrospect, he had an old house, and he had some bats in the attic. And he tried to catch one time with his tennis racket and get it outside, and he probably got bitten by it. But it wasn't really an integral part of the history. Oh yeah, last week I just had a bat, and then I tried to get outside. But anyway, most of the time we make the diagnosis of rabies post-mortem. And, there isn't really any really good treatment for it. But this was pre-mortem. But unfortunately, despite a lot of publicity and a lot of help from people around the country who were suggesting various things, the guy ended up dying. But it was a very interesting case. And from now on, every time I call that dermatologist, I say, "Remember last time I was right, and maybe you should come in this time."
Nice.
So I'll be right there.
That is rare. I haven't even heard of that, like being diagnosed alive when the diagnosis was made. All right.
This was 22 years ago, so that's the last case I think we had in New Jersey.
Wow, crazy. Dr. Anton, are you on? That you have an interesting case?
Yes, I'm somewhere in the background. Um, yeah, many, you know, but I thought about this now, and what triggered this one is actually a very, very simple case, and that was a stop of a dental bleed, you know, because as one of the previous speakers said, you know, to get a dermatologist in the emergency room is somewhat of a challenge, but to get a dentist after hours in the emergency room, that's not challenging, that's impossible. And this orthopedic surgeon colleague of mine, he had a dental extraction, and late afternoon it started bleeding, and then later in the evening it really started bleeding. And you know, a lot of people believe that you cannot bleed out with a dental bleed, but believe me, you can land yourself in surgical shock with a dental bleed. And so around about 12 midnight, they called the dentist. He didn't answer his phone. So they started, you know, using the dentist in the area, and some answered the phone and gave good advice, and some just didn't answer the phone. And eventually by about 2, 3-ish in the morning, they called me. And, you know, as a maxillofacial and oral surgeon, it's not, you know, we get up at nights, it's not a problem. And I went out, and I don't think it was more, well, let's just make it 10 or 20 minutes, and the bleeding stopped perfectly well with just, you know, some dental sponges and tight suturing and a bit of local anesthetic with adrenaline. And this orthopedic surgeon colleague of mine, he was so grateful. Every single year on my birthday, a lovely bottle of wine on my table at my practice. And yeah, so he eventually emigrated to Australia. But that was memorable, very, very nice case. Very simple, just like, you know, have some empathy, you know, towards your colleagues, but also towards the people in the ER, your emergency room physician. You know, a very simple thing, but if somebody doesn't get out of bed, it's not going to happen.
Yeah, yeah. And then I do have a, actually that's a fun question, Chloe. I know you just sent it to me, but I'll tell my case in just a little bit, but a question I've been getting from numerous students that's probably nothing to do with medicine, but John and Don, everyone keeps asking if you guys are twins.
No. I'm a few years older than my brother Don. He's my younger brother.
Even though I have the white hair.
I've gotten that question even last year. Not even kidding. My most memorable case was actually